So, welcome to the CAPS portion of today's LGBTQ health disparities presentation. My name is Dr. Stovall. This is Dr. Wunderlich, and we're here representing Counseling and Psychological Services, better known as CAPS on the campus. The first part of our presentation is really going to be going over the colorful handout that we just passed you guys, so you can follow along at your own pace, but that's where we'll be starting. Front page. Yeah, we had quite a bit to hand out, so the most colorful thing in your hand. So we wanted to tell you a little bit about our organization, how we're a resource for the LGBTQ plus community, how we're committed to developing ourselves as an organization, and our commitment to development of staff competencies in this area. Did you need? So first off, I'd like to start by telling you about the services we offer. You'll notice that at the top right. Our services include individual, couples, and group therapy, as well as outreach, crisis intervention, and consultation services. And we put one example on there called Let's Talk, and that's a consultation service for students where a clinician is housed in various departments across the campus at different times in the week, different time slots, to make CAPS more accessible to students. It's not traditional therapy, it's more for dropping in to get quick solutions to things, time management type issues, and support. But if the clinician determines that this student could really benefit from some traditional therapy, then we'll make the referral to CAPS.
And some of the locations that we have a location in the law school, we have a location, I think, at Applebaum,
Mm-hmm.
right? And then
Jigsaw, which is third floor of this building. Student Veterans Office, which is the sixth floor of this building. So we have several across the campus, and we're trying to expand to match the student need.
yeah. And if you want to know the specifics, just look on our website and you can see where it says Let's Talk, and we give the exact locations.
Mm-hmm. CAPS is also proud of the growing diversity of our staff. You'll notice the top left where we have diverse racial and ethnic backgrounds, various ages of clinicians, excuse me, members of the LGBTQ community and its allies, as well as varied disciplines and positions. We've also been committed to developing our competencies, and we've listed several ways that we've addressed that so far. So clinicians have attended ally trainings throughout various parts of the year, and we like to attend often because only once in this area is not enough because things are changing and we want to be as comprehensive as possible. We also have our clinicians attend regular professional development meetings, and each discipline actually requires that we continue to increase our knowledge on issues of diversity overall. We also listed how CAPS specifically is trying to match this need. These are the things we've done so far, like creating the diversity committee. We've also posted signage that says all are welcome here, and that's even displayed in various languages. And you'll notice that as soon as you step off the fifth floor elevator, you see a sign there, you see another sign right at our front desk, and another sign in our waiting room. So we love to let you know that everybody is welcome there. We've also updated our documentation to reflect this. We've added preferred name, preferred pronoun, and even changed marital status to partner status. Again, we're trying to be as inclusive as possible. So continuing on the handout in that bottom left talks about some of the disparities that Ruth Ellis likely went into more detail about, but the highest two that they were mentioning were depression and suicide. There's also a large disparity in the healthcare for LGBTQ community in finding appropriate and affirming healthcare. And so in just a minute, I'll actually be turning it over to Dr. Wunderlich so that way we can talk about how to actually address that in the healthcare setting, okay? Before we get to that, in that bottom right on the first page, we talk about ways that you can help support members of this community. So if you or somebody that you know is struggling from some of those disparities, we're definitely encouraging you to refer them to CAPS. The College of Education also has a counseling center, and Wayne State also has the psychology clinic. So there are several clinics on campus that you can walk a student over, generally let them know the website, just be that support. If you or someone you know is suicidal, there's also, or we encourage referring to those same places, but we've also passed out a lot of the little forms that you guys, little packets, that will tell you how to recognize signs and symptoms of struggling or signs and symptoms of suicide, so that way you can get that student help. We've also included the Student at-Risk Training module, which is offered through Cognito, but it's part of the SAMHSA and Suicide Prevention Initiative that's going campus-wide. So that Student at-Risk Training module actually takes you through like step-by-step of recognizing those signs and symptoms and how to get help. We've provided the link on the bottom for you and the enrollment key. So it's open to students to take that, and we're trying to push that initiative. We actually have Stephanie here who's part of that initiative, so if you have any further questions of how to get involved and part of that training, she's also here to answer that as well.
It's super easy. Pretty much Wayne State, 5 minutes, I don't want to take over anything. Pretty much, long story short, Wayne State got a big grant to implement suicide prevention Wayne State campus. And suicide prevention won't work unless we encourage all students to look out for each other. What's on the flyer, it's called Cognito. It's 20 minutes, online training. It's entirely free for you with that enrollment key. Just enter that enrollment key. You can complete it, you can take a break, come back to it. It's pretty easy. You get a nice certificate as proof that you did that training afterwards. You can always add that to a resume if you want to make yourself look really good. Say I've been trained in working with students at risk or students showing signs of potential suicidality. But all the other little cards, I'm sorry, those are all from me. But if you ever need more, I have a ton more. One of the cards provides you information about all the mental health services available for you on campus, like Vivian was talking about, not just CAPS, but College Vet, the psych clinic, after hours phone numbers, National Suicide Hotline, the crisis text line. If you don't want to talk to somebody, send them a text, and they'll be able to get back to you. But if you have any questions about Cognito, what Wayne State's doing for suicide prevention, if you want to get involved, we have a student group that's formed, a student advisory board. I'm always looking for help. I don't have any fancy business cards yet, because I ain't going to make them until we have our website up, because then I can put our website on there. But on the sign-in sheet, you'll see Stephanie Cassie. Feel free to take down my email. I respond to emails pretty quickly. But yeah, Wayne State is here for you. We do want to make sure that the LGBTQ community is represented in all of our mental health and suicide prevention efforts on campus. And off campus too, a lot of schools.
Thank you. So now I'm going to hand it over to Dr. Wunderlich.
So before I start talking more, what I noticed that people were coming in late, and just want to know that all the handouts were coming out of the bag from the people. So feel free to grab those on your way out if you didn't. So I'm going to shift just a little bit, and we wanted to talk about our understanding that a number of you in the audience might be from doctors and or public health professionals and maybe doctor offices. So we wanted to shift our conversation with how would an upcoming doctor or medical office, what kinds of things they do to address these disparities that we're talking about. I'm sure you know all about that. We identified 5 major areas to kind of consider, but we're going to highlight one in particular, and we're going to have you guys help us work through some situations to figure out how things could be improved. That part we kind of think about. But in the 5 areas we addressed, there might be more. This is just what we thought of. If you guys have any other ideas to add to it, let us know.
And it's on the back of your first page.
Right. So this is behind the whole page. So the first thing, the first box is understanding the cultural context of patients. So if a patient comes into the doctor's office, sometimes assumptions are made about their cultural background, or about their race, or ethnicity that may not be valid or accurate, about their orientation, or preference. And so just the first step is to be aware of the fact that sometimes those types of assumptions are made, they need to be questioned, not just assumed. I don't care what my dad used to tell me about what that means. Anyway, the second box is modified practice and policy, modified practice policies and environments to be inclusive. And so we talk a little bit in that regard about different types of forms, intake forms, paperwork. Okay, and on the back
the second handout, there's a white piece of paper. It's got some bullet points. And on the bottom, we give some examples of better ways to construct intake forms than some of the more traditional ones. And like Vivian was saying, even at CAPS, we've been looking at that and trying to update our forms to be more reflective of inclusivity. Let's see, we've got take detailed, open, and non-judgmental sexual and social histories. And so we're going to talk about that a little bit more in depth, so I'll come back to that one. And then also for the employees in an office to engage in self-education on health issues that are of importance to the patients. And I know there are a lot of disparities in the types of health issues that different members of this population have to deal with, and so it's good for the medical professionals and their supporting staff to be aware of that and understand that. And then also just like finding a way for staff to engage in dialogue around personal attitudes that we might hold that sometimes we're not even aware of that are not affirming. And, you know, to find the strength and the courage to help let each other know when we're transgressing, and to find gentle ways to say, you know, maybe you could consider how this might come across to a patient that you're working with, and make some challenges that way. So if we come back to taking the social history, we want to break that down a little bit, and we're moving down into these boxes on the bottom, and we apologize, they're a little blurry, but that was our type font, so we learned a lesson, pick a different type font next time. That doesn't come out so blurry. But anyway, so one thing is to during the interview itself, is for whatever medical professional is conducting the interview, is to really try to focus on asking open-ended questions rather than closed questions where a person could respond with yes or no. And then also mirror back to the person what they're saying to you so that they know that you're hearing them and that you're taking in what they're trying to share with you. And then also be sensitive to using the pronouns, the preferred pronouns that the person has let you know that they would like to be addressed by. And then as the person opens up and starts to talk about what their particular problem is or health issue, is to provide reassuring responses, you know, affirming responses, nodding, indicating that you're being attentive and that you're listening. And then also there might be, let's see, I guess inclination to want to give advice to a person maybe about how they're handling their coming out process. Maybe a medical professional might think that person should hurry things along or maybe slow things down, and to really be attentive to that and not try to interject our thoughts and opinions about how that person should be going through that process. And then the last box we've already addressed is, you know, in terms of some of the, well, I guess in the interview as well as the forms, so instead of saying, are you married? Or instead of saying, do you have a boyfriend or girlfriend? Instead you can say, do you have a partner? And again, that's a more open-ended way of asking that question. Okay, so is everybody okay so far? You following? Okay, so what we'd like to do now is we want to introduce to you, we're going to need some brave volunteers to help us out with this. We want to introduce a couple different scenarios that we as a group can work through together. And as you're thinking about these scenarios, for those of you that are not volunteering to read from the script, you can pay attention to these numbers 1 through 9 in terms of just giving you some guidance on having some ideas as we have for the discussion that we're just about ready to enter into. So what we're going to do is we just have a brief, 2 or 3 brief scenarios. We have a role for a patient, role for a doctor. So we need 2 volunteers for the first one, and then we'll need 2 volunteers for the second one and 2 volunteers for the third one. So one person will read out the script for the patient, the other for the doctor, and then at strategic points we'll say stop, and then we'll ask everyone else, you know, what are your thoughts about how this was handled? What would you suggest that what could be done differently to make this a better interaction? Okay, so do we have a volunteer to read off the script for doctor? Okay, and patient? Okay, great. Okay. Okay. All right, thanks. So, do you want to be the doctor or the patient?
I could be either one.
Either one? Okay, come on up here. How about you, doctor or patient?
Oh,
She gave me the doctor one. So
A doctor one? Okay. So you're gonna.
I don't care.
You're gonna read it?
All right, guess I'm the patient.
Okay.
All right.
Now, if you guys want to come on over here closer so that
Oh,
she
to
can
the
get you
mic.
on the
Yeah.
camera and to
Sure.
the mic, yeah. And then when you see the stop sign, we'll stop and ask people for their input, okay?
All right.
Hi, I'm Dr. Double X. I see this is your first visit here.
Yes, I've been nervous about seeing a gynecologist, so I've been putting off coming here.
What brings you here? How can I help you?
Well, I'm a little embarrassed to talk about this.
That's okay. Lots of people feel nervous the first time they come to my office.
Well, I'm having pain during sex.
How long have you been having pain during sex?
Well, for about 6 months.
Have you talked about this with your boyfriend?
I don't have a boyfriend.
Okay, stop.
So how did you feel about that scenario? What implications was the doctor making? We'll start with that before we look at what could be done differently. Yes.
Would you say that the doctor assumed that she had a boyfriend? It could have been a female person.
Partner, romantic partner. Non-specific.
All right, so we'll continue. Okay. All right. So who are you having sex with? Oh.
Yeah, is that a problem?
Any ideas? Any thoughts? Stood out, right?
What about that stood out? How did you even feel in that situation?
I guess that's cute.
Maybe ask if they use protection instead of just condoms. Like, there's lots of different kinds of forms of protection. Maybe, sort of feed into those questions a little more gently. Like, hey, we're going to talk about a variety of things today. We'll go through this, and this, and I'll ask them some questions about your sexual activities or relationships or what some other, instead of bursting.
Yeah, that did go.
All right, great. All right, so continue.
No, I'm a lesbian. Okay, well, I assume you don't have children.
And we know that we're fluffing it up a bit, but the sad thing is, it's not too far off from what people experience. So we're purposely making you think about these things, because there are many things that go under the radar that we feel a little twinge when asked, but we don't really follow what we wanted. So how do you think the patient felt in that situation?
Hurt.
Yeah.
And the patient would have felt hurt.
Yeah, like if she didn't have a child, it would kind of make her seem like, you got this thing that she's fixed, like have that child.
I don't feel comfortable. I don't feel like I can adequately express the needs that I need because now I feel like I'm being judged. So I can't safely express what I need.
So it's closing them down and sort of figuring it out. All right.
Oh no, I do have a son. He's 10 years old and is everything to me. My partner is in the lobby. Can I ask her to come in here?
Well, I guess.
I mean, way to go for the patient standing up for herself in this case, like,
Pushing forward.
yeah.
That's a really great observation, because it's really hard to stand up to medical doctors sometimes. People feel intimidated that medical doctor's the expert, and I'm afraid to correct them or maybe get my needs across if I think that they're going to judge me.
It would have just been yes. If it was hetero couple, probably. We wanted to talk to you about getting pregnant. We want to have another child.
Oh, okay.
My girlfriend gave birth to our first child, and now I want to give birth to our second child.
How do you want to go about doing that? I think it's important that children have both a mother and a father. Children suffer where both parents are not involved. And boys really need a good father figure, a male role model.
Oh my God.
We end the scenario with a bang.
I'm just gonna heap as much judgment on you as I can right now.
Do you think it's possible that someone might have a conversation like this with a medical professional?
Yes,
That's that?
100%.
Yes.
Unfortunately.
Yeah. So it's so wonderful that you guys are here learning how far away.
Sorry, how did that start out again? The doctor's response, how did it start out?
Oh, how do you want to go about doing that? I think it's,
I think stopping there.
yeah.
Just after that.
Yeah, exactly.
You think it can't get lower?
Yeah.
What were you reacting to?
I was just thinking like, well, that response is kind of like, well, if you're the doctor, you should be able to talk about the options with patients that you're talking about. Asking like, oh, how do you want to go about doing this? Like, this is something that they haven't tried to familiarize themselves with, is how people want to deal with family planning issues.
Like, we can talk about options,
Yeah.
maybe a good way to,
Yeah.
better way to start
Yeah.
that.
Or even asking, I guess, like how they went about it the first time, or, you know, like what options do you already know about, like, and then helping them expand on that.
Let's assume you're a competent person who knows things.
Well, I'm gonna be honest, I probably would have left a long time ago.
Yeah, and unfortunately, that happens a lot, I think, you know, when people are trying to find someone they can feel safe with.
Absolutely.
And so, you know, it's, I think it makes it, not that it's a patient's responsibility to educate the doctor, but, you know, anything that we can do to help them understand when they're making these transgressions is really great. Okay, thank you guys. Okay, one final scenario. And we'll look one more. We have more volunteers. Some volunteers. That's big. So we need, okay, and we need one more person? Either one. Okay. All right. Start here and here. Okay, and then we focus here, and then we go over today.
Hi, my name is Dr. XX. Let's see, your name is Andy, right? Oh, I'm not. Oh, I'm sorry. Of course I haven't.
He reaches to shake hands and he doesn't respond.
Yes, it used to be Andrew, but I changed it to Andy.
Why did you do that?
I feel more comfortable as a girl. It took me a while, but I finally got my parents to agree to let me dress like a girl and makeup.
Oh, let's see that. So Andrew is your real name because you are male by birth.
What are your thoughts on this?
This is not medically relevant, just call her by the name she wants to be called by. How did you feel?
Well, I mean, I think the use of real name versus, like, Andrew's your real name, like, that kind of puts weight on it, right? Like, that says, I'm not going to call you by this name that you've given yourself, which I'm assuming to be fake or whatever. Like, it puts so much judgment onto my identity.
And maybe if there is a legal necessity to ask, you could ask something like, so Andrew is the name that would show on your insurance documents instead of, so it's your real name, right?
So a much better way to ask that, to frame that question, if there's a need for it.
And so she knows why too, like why it's relevant to ask instead of, I just want to call you the wrong name.
Yeah, I didn't know what to put on the form because your form only has male or female. I identify as trans.
How can I help you today?
Well, I've not been to a doctor in years, and I finally got health insurance, and I need to resume my hormone treatment. But that was not why I came today. I'm not feeling well.
Are you sexually active?
Yes.
With men or women?
Then
Oh, so so you are a male having sex with men. So you're just a gay man.
What are your thoughts?
I mean, like, I do see it, like, a lot of, like, HIV literature, like, MSN being used, like, quite often, even, like, when trans women are, you know, implied to be included in that group, so, like, I do kind of see that as, like, a problem that needs to be addressed, like, in all levels, and, like, the research level as well, not to, like, excuse that, because, of course, like, we should do things for the patient, but, you know, it's sort of a systemic issue, I feel like.
Because this didn't surprise you, this response.
I mean, yeah, it like, it's not nice, but, you know, it's also, you know, I think that there's a really big bias against, you know, trans women in the medical field that comes from, you know, or at least it's, you know, enhanced by and it's reinforced by labels such as that.
This doctor seems to be very confused on the difference between gender and sex. I'm not really sure what to say.
I think the doctor minimized her whole experience. Just kind of said you're just a gay man, or so kind of put that person into like a box, and just kind of really didn't look at them as a person.
Put them in the wrong.
Does it really matter if I'm in a box at this point? Like, medically speaking, like, do I really need the label of, in this case, well, you can, as a gay man, like, as if that has some relevance to anything that we're going to talk about per se.
Right. She said that she came in because she's not feeling it. Yeah.
And like, even if it does have something to do with my sexual activity, like, why does it matter if you give it a name? No, I identify as a trans woman. Not at all as a gay man.
You know, I'm not really up on treating transgender people. Maybe you should see a different doctor.
I'm sorry, what was the last line that you said?
Sure. You know, I'm not really up on treating transgender people. Maybe you should see a
I walked in and it was like, bam, ooh.
So, like, up on is like not feeling, I'm wondering, like, is there a bias here from the doctor, just like not wanting to treat someone who's transgender? Or is it someone who, or like really feels like
Like a lack of confidence.
yeah, like, yeah. But I think that those are also good questions.
Or lack of knowledge, I think he doesn't know how to, I mean, he has to be specialized in,
So giving the benefit of the doubt, it's a lack of knowledge and confidence in that area.
Or maybe it is the one experience.
Back to, bias, not feeling comfortable.
It takes her and makes you not a person. That he's not up to date on treating transgender people. You're a person, so you should be up to date on treating people. But he's taken you and placed you outside of even people.
And you're also not there, like you talked about hormone therapy, but you were there because you weren't feeling well, which, I mean, should just be treatment across all boards.
Yeah, and this would also be, let's say, that was kind of hard there. I was trying to say, where is that on the script? But, yeah, and I was thinking too that, you know, even if we give the doctor the benefit of the doubt that this is really an acknowledgement that they lack information, then this could be seen by the doctor as a growth opportunity and as an opportunity to learn more rather than to reject information.
Like, I think it could be even appropriately addressed as, like, I think it's important to be honest where, you know, if I had specified that I came in for hormone therapy, which I specified that I didn't, then being honest that that's not something that you have experience with, I think that could be appropriate.
but just like jumping straight to the agency, a different part of it.
Yeah, I think the doctor's delivery, of course, wasn't good, but I think he did her a favor. He did the trans person a favor, in the sense that to kind of say that I can't really necessarily help you, that means that person can go somewhere different, versus maybe some people may not be strong enough to kind of move on and find somebody different and end up doing more harm than good.
That does assume that I have more options. I
Absolutely.
have limitations to my health insurance, for example. Or they might not feel comfortable going back. Like you would hope that it's a favor and hopefully I don't have to deal with somebody who's not competent, who doesn't care about me as a person. But a lot of times that might be the stop, unfortunately.
Absolutely.
Maybe it should be a thing like, I don't, like, personally, I don't think doctors should have like a personal bias, but if they did, maybe they should at least have some sort of reference to give people, if they are trans, they don't feel comfortable treating trans people, you know, at least do something like that, so to be like, oh, I don't feel comfortable treating you, so, you know, oh, well, you know.
So instead of saying like you're on your own,
Yeah.
here's some resources and people like that. Yeah, this is, I think, a very complicated question in terms of if a medical professional feels a competency or not. And then what is their obligation if they don't feel a competency? Really good points.
Well, okay, but I really just need treatment for what I think is strep throat.
Okay, I will check your throat and test for an infection. Nurse, can you please give him a script for a blood test?
Then we say more. Yeah. So anybody want to comment on that last Thank you guys so much. A big round of applause to all of our So yeah, we just wanted to give kind of that hands-on experience and get you thinking about how you would interact with somebody in your practice or in the healthcare profession or just as a human being. So we wanted really that hands-on experience. So we hope you enjoy it and we hope you enjoy the rest of it as well.